My name is Alastair D Lamb, a urologist from Oxford, and I've been asked to address the question of what to do with men you do not biopsy or whose biopsy is negative. I have no potential conflicts to report. Of course, there are these two clinic scenarios that we're talking about. First, a patient sits in front of us with a negative MRI and is asking, if I don't proceed to a biopsy, then what's the chance we could miss cancer? And the second scenario, and of course, this is a bit more like what we've been doing in the past few months, and the man asks, so I had that biopsy after the MRI and it was negative. Could I still have cancer? So let's deal with this first one. First, my MRI was negative. What next? Well, we undertook a systematic review and meta-analysis of all studies in the PIRADS era to determine the negative predictive value of a negative MRI for clinically significant prostate cancer. What's going to happen if we have a negative MRI and don't biopsy? We assessed the usual definitions of with or without PIRADS 3 for negative MRI and with or without Gleason grade group 2 for clinically significant prostate cancer. Focusing on what is probably the most widely accepted definition, PIRADS 3 to 5, and Gleason grade group 2 or above, the summary statistic is a negative predictive value of 91%. In other words, the answer to our man's question, what is the chance of missing prostate cancer if I don't have a biopsy, is 9%. But there's an important second message here, which is that this data is rather heterogeneous. And we've endeavoured to communicate this with this heat map that you see on the left of the forest plot. So let's look at this in a bit more detail. Zoom in here and see what's going on. Focusing on biopsy-naive men with a negative MRI, we see quite some variation in the magnet strength, brand, and the true positive from truss to mapping TP. And the forest plot shows this variation numerically. Therefore, while the summary NPV is 91%, it's really important to know the performance of our own MRI scanner, radiology team, and biopsy protocols. So, the MRI is negative, but is it really okay not to biopsy? Well, those odds are pretty good, but there are a few exceptions. And first we have PSA density. There's increasing evidence that a PSA density of greater than 0.15 is a useful safety net for catching men with important disease, even with a negative MRI. The Netherlands highlighted this in an important borderline patient group with PIRADS 3 lesions. They found that in this getting on for half of men with PIRADS 3 lesions could have avoided biopsy if a threshold PSA density of 0.15 had been used. Importantly, in their series of 1,057, only 6% of men with a PSA density of less than 0.15 would have missed an important diagnosis of cancer. Of course, there is still some debate about this threshold of 0.15. This did look at a range of PSA cutoffs, and I don't believe there's any obvious step point as you continue through these different thresholds moving across the table. But PSA density of 0.15 does seem to be the most universally popular on expert consensus. So, as exceptions, we have PSA, of course, patient concern, because really this is about a person's attitude to risk. And so, in actual fact, it's more like a discussion not with a doctor and a patient, but rather a financial advisor and a client. We need to get good at communicating risk. And as we get better at this, patients will understand that these tests are not binary. What is your philosophy of life? How do you plan your affairs? Well, that will affect the decision here. And then, of course, there's a third factor, which is about the quality of the MRI. For example, metalwork or characteristically inaccurate MRI in younger men or very large prostates with small squash peripheral zones. Then we might decide to undertake systematic biopsies regardless of the MRI finding. But if we've decided we're not going to biopsy, then we come back to what do we do next? Some might think, well, this man's been flagged, we should keep a close eye, meaning regular PSA, clear guidelines to our GP colleagues for re-referral, and possibly repeat MRIs. By contrast, we might conversely decide that these men have had more investigations than most, a PSA and an MRI, and so their risk is lower than the average man on the street, and we should say cheerio. Where we sit on this spectrum will probably depend on our philosophy of screening. So, in conclusion for this first part, there needs to be an emphasis on patient-centered decision-making, and we need to have the data at our fingertips. We need full disclosure of the risks or otherwise for different management plans, and ideally to know our own data. We should keep the option open for a biopsy, even with a negative MRI for the exceptions discussed, and we need to agree a follow-up plan and where that will take place. What do the guidelines say? Well, they agree. In summary, when the MP-MRI is negative, it is reasonable to omit the biopsy based on shared decision-making with the patient. But the evidence is weak, not just because the NPV paper wasn't available when these guidelines were last updated, but because none of us are quite sure what is an acceptable false negative rate. So, more quickly, let's move to part 2. My biopsy was negative. Could I still have cancer? Let's start with the guidelines this time. When the biopsy is negative, but the MRI is positive, then further biopsies should probably be done. And they should definitely be done if the clinical suspicion of cancer is high. For example, a high PSA, we come to PSA density, or an abnormal GRE or local advancement on MRI. So the biopsy is negative. Is it okay to leave it at that? Well, let's have a look again back at the bottom section of our forest plot. Negative predictive value in men with previous negative biopsy. So if the biopsy is negative and the MRI is negative, then as expected, the MPV rises a little to 93%. Let's zoom in again. There's a bit less variation here in magnet strength, although still quite a range of true positives. And on the forest plot, we see the same. The key message, of course, is know your own data. But if you don't, then this 7% false negative stat should be useful in these discussions. MRI was positive and the first biopsy was benign. Well, then things are different. And it all comes down to whether we trust that first biopsy. We prospectively collected data and PROMs on 1,218 men undergoing LATP at 10 centres during the initial adoption of this technique, presented at AUA last year and currently under review. Of these, 257 had a previous trust biopsy, many of which were found to have cancer at TP. What's going on? Well, there's a decent possibility that transrectal biopsy is simply less effective at targeting MRI lesions. In those men with a previous negative truss, but who had PIRADS 4 or PIRADS 5 lesions, we found clinically significant prostate cancer in 34% of men. Importantly, this increases to 49% in men with anterior lesions, a phenomenon that many of us are, I think, now familiar with. TP is much better at hitting anterior lesions than truss. And finally, there's apical lesions, perhaps less well studied than anterior lesions. But Peter Pinto and his team showed that a third of men had clinically significant prostate cancer on rebiopsy after previous negative truss when the lesion was down here in the apex, presumably because of the difficulty in getting there transrectally. These are some other adjuncts that can be used in this setting to help decision-making, but they are not currently recommended in European guidelines. So what do we do if the biopsy is negative? Well, if we're happy after the financial advisor discussion that the patient does not want any further biopsy, then the same two philosophies as before apply. But if there's genuine concern that something could have been missed, then we should repeat the biopsy through the transperineal route. Of course, we have to ask the question of whether we shouldn't just have done the TP biopsy first off. So, in conclusion, these are the main messages and the evidence. Thank you very much for listening.
These came back from a search.